Hi, I'm Dr. Scnhee with Holton Community Hospital Weight Management Program.
Just tell me about even dating back to what got you to want to get into medicine.
Well, that goes bac a long ways. I've wanted to be a doctor since I was about in third grade. I really had a pediatrician that was awesome, and I actually enjoyed going to the doctor, and he would teach me things while I was doing that. And so I actually wanted to do pediatrics since about the age of 8 or so, and never really veered too far from that. Thought about cardiology for about a month, and that was about it. And so when I got to medical school, I decided that's where I was going to go. I was going to do pediatrics. And then during third year, I did a family medicine rotation, as we're required to do. And the family medicine doc I worked with said, by the end of this rotation, we'll get you doing family medicine. And I thought, after 16 plus years of wanting to be a pediatrician, I doubt it. And he did. I really enjoyed that rotation. With family medicine, I was able to do pediatrics as well as a lot of other things, including delivering babies, which I very much enjoyed as well. So that's how I got into family medicine.
So rewarding kind of experiences that you've had thus far. What's kept you in medicine?
So it's just very enjoyable to visit with patients, to learn about them, try to help them through whatever struggles they're going through at that time. And then also trying to prevent struggles, trying to prevent problems down the road. It's always been something I've been focused on as well.
So you got a history of family medicine and pediatrics. Now your specialty is in obesity medicine. What transitioned for you with that?
So I went through a journey with a family member of mine who went through a significant weight loss journey several years ago, and lost a significant amount of weight over a couple years. And during that time, they sent me studies and wanted me to read books and just kind of visit with them about different things. And that really got my interest even more. I always had some interest in it, but a little bit more than it had been there before. And then after going through that, and then with some changes with various things with the urgent care medicine that I was doing before, I was looking for something different and thought that would be an avenue that I'd like to go down. So I started doing some education and learning a lot, doing many hours of education, and looking at getting board certified in obesity medicine. And so that's kind of what drew my interest into it.
Your journey being a doctor at Holton Community Hospital with obesity medicine, can you tell me about that journey?
Sure. So I was at Holton Community Hospital previously doing primary care, was here from about 2007 to 2016. There were a variety of things going on. I ended up needing to change, and so made a change there in 2016. And then as my interest grew in obesity medicine and I got more education, I was looking at joining another already established practice. But I visited with one of the doctors here. I still kept in touch and had a lot of ties to Holton Community Hospital. And so talked with them about what I was looking at. And after discussing with them, we thought maybe that was something we could start here. And she felt like she had patients that might benefit and felt that others would as well. So we ended up speaking with our CEO. She was excited about the possibility, and things kind of took off from there.
Awesome. Obesity medicine in general, weight management. What does that mean?
So it's really looking at obesity as a disease. That is the main thing that to me has actually been, my eyes have been opened over the past few years as I've been looking at this. Obesity in the past has often been looked at as a willpower issue. It's just something that a person almost chooses, right, to have a weight issue. And it really is not that way. It truly meets all the criteria for what a disease is. It causes multiple functional issues in various organs of the body. It has a biochemical underpinnings that is a derangement in the biochemistry of the body. And so really looking at it as we would diabetes, high blood pressure, cancer, any other disease you can think of, we need to put obesity into that same category. So obesity medicine specialists are specially trained and have undergone special education, that looking at causes of obesity, treatments for obesity. And so that is where, even though we're focusing on one disease, it touches base with so many other things that it encompasses all of that as well.
So is it fair for me to ask, I guess, that there is a stigma or a certain perception that, well, you referenced the obesity is something that people just choose to do, but what you're saying is that there's way more behind the scenes that people don't realize with it.
That's absolutely true. So there is just this perception that people choose to live that way, and if they just would eat less and move more, that the obesity would all of a sudden be cured. And we know that's not true. It's interesting, if we look back in history, that's actually how people looked at diabetes and high blood pressure and high cholesterol. When medications and different treatments for those things came out, they initially were looked down upon by the medical community and by the public at large as being a waste of resources. Why are we developing medications and treatment for these conditions that people could just change their lifestyles and that would get better? We obviously nobody looks at those conditions now that way. And so we're trying to get people to also put obesity in that category, that it's something that has good treatments and is much more complex than a simple eat less, move more kind of mentality.
Interesting. How do you approach setting health and weight goals for your patients?
So I try to use actually a mnemonic that's called SMART, the SMART goal mnemonic, and that stands for specific, measurable, achievable, relevant, and time oriented or time bound. And what that means is that we look at what can we do, what is achievable in a person's life with their specific struggles and everything. What can we do? And then we put a specific number or a specific time frame on that goal to try to reach it. That makes it much more easy to know, did we reach the goal or did we not? And if we didn't, why didn't we? Kind of looking at the reasons why that might be, as opposed to just nebulous goals that it's hard to know whether you met it or not. I look at both short-term goals as well as long-term goals. So, look at what can we do in the next month and what changes can we do, but then dream big. What can we do over the next year or 2 years over time?
Okay. What are some challenges that you face as a provider with your patients who maybe struggle to meet that goal?
Sure. So as far as what I try to do initially is I try to, again, get as much information as I can. Weight concerns come from a lot of different things, and our eating habits, our exercise habits, and those type of things have developed over years and decades, and there's reasons for them. Even things down in childhood affect how we do things as adults. We all understand that. And so trying to get at those specifics of what is the reason for certain eating behaviors or certain other attitudes and behaviors, maybe misconceptions about either nutrition or health in general, and then trying to see what can we start changing. Sometimes there's a lot of things that we need to try to change over time, and we can't do everything at once. So we try to just focus on those things we can initially. As far as other struggles, though, each person has individual stressors, individual family dynamics that can make it more challenging, and that's kind of part of the fun of being an obesity medicine doctor, is taking that information and then with the patient working together to try to come up with a plan that will work for them.
Everybody sounds unique in their own struggles with it. Is there something that you kind of hang on to that you can have for each patient, no matter their circumstances, to try and at least get the ball rolling? Sure.
So the main thing that I focus on is what are called the pillars of weight management. And that's not a term I came up with. It's a term we use. And it focuses on 4 different areas that we try to come up with a plan. The biggest one of those is nutrition. And so generally there is something from a nutrition aspect that we can change, even if it's, small things or big things, just depends on the person and what exactly is going on. But usually there's something there that we can tweak that can make a difference. As far as the other pillars that are involved with that, another one is physical activity. And that's not just exercise. I try not to use that word. Exercise is really a scheduled time. I'm going to go spend 30 minutes doing this activity. Physical activity really involves everything you do that's physically active. So that involves, parking further away and walking more, or getting up if you have an office job, getting up and moving around every hour or half hour if you can. And so looking at those options there. Another area is called behavioral modification. That's a big bucket term that includes a lot of different things. It's looking at what behaviors, attitudes, thoughts we can change around food, around activity, around a lot of other things. That's where I talk a lot about sleep, which is really important for health and weight loss. It's also where we talk about stress and stress reduction. All of those things kind of fit into that category. And then we also talk about medical management. So that is looking at medications, looking at surgeries, other procedures that can be used too as well.
Well, you kind of go into my next question about, you mentioned surgeries or potential. What technology and techniques that are you able to use with obesity medicine?
So technologies we use a lot. So one thing that I often have people try to do if they can is doing some sort of food tracking where they manage and focus on what they're eating and keeping track of that. So in the old days, that used to be you had to have books that told you all the information and you'd have to look it up and write it on paper and add it all up yourself. Nowadays, most people use smartphones for that and use smartphone apps. So they use that technology to help keep track of that. It gives way more information. Some of these apps track your vitamin A and vitamin C, things that, to me, may be interesting to look at, but not all that important from a weight loss perspective. Also, wearable tech for fitness, that is very popular right now, where you wear devices that track your activity and can even interact with those smartphone apps and your food tracking. I also do something that we do here at the hospital, which I'm really excited about, is something called a DEXA scan, which we use for body composition. So a lot of people may have heard of DEXA scans for bone density. It's the test that we use to look for osteoporosis and thin bones. But we can also use that same scanner to look at body composition. So percent body fat, muscle mass, lean body mass. And what I use that for is couple things. One is to look at, with knowing a person's muscle mass, we can actually know their calorie needs more specifically and more accurately. So I use that a lot for that reason. And then also with time, we can track those scans and see when people are losing weight, are they losing the fat tissue that we want to lose, and hopefully maintaining as much as we can the muscle tissue that we want to keep.
So it sounds, a lot of people focus on caloric deficit or calorie as a focus. What you're saying with this DEXA scan is that you guys can almost pinpoint a plan based off of the scan.
Yeah, the scan helps us with a lot of other modalities and knowing exactly what might be right for the patient.
What are some goals for improving somebody's health here in Jackson County and in Northeast Kansas, really? Mm-hmm. What are some goals that you've set for that?
So I focus first on the individual, because that's generally most of what I do is focus on the patient that's working with me and trying to give them education, setting goals, and getting them to make some healthier life choices. But along with that, I have already had quite a few patients that have taken the information and their successes that they've gotten from visiting with me and taken that back to their families, back to either parents or brothers, sisters, or friends. And they have shared with me that those people are now making some changes. And even though they're not my patients, I just really enjoy hearing those stories of other people making changes, because they do see the changes in the people I'm caring for. So I feel like can be some spread of some healthy information and health changes through that. Along with that, I've done some talks out in the community and tried to share some information with regards to specific topics or just generally about the program, and try to reach people that way as well.
So the ripple effect's been pretty fun for you to sit back and just kind of watch as one patient's had success, it's rippled through. Is that something that you hoped, again, it all starts with, one patient with you, but that can come back as a success overall for the program?
Absolutely, because to me, I just want to try to get the community healthier. Obesity is a major problem in our community, just like it is pretty much everywhere in the United States. And so trying to make those changes, at the ground level, and then trying to, look at ways to build programs or ways to improve in other ways is important as well.
So how do you plan to increase education about nutrition, activity, weight loss throughout this program?
Yeah, so I'm hoping, again, through talks, through different locations and things like that. I'd also, through things like this, through radio and being able to provide education that way, working with our marketing director and trying to find different avenues, different ways to get information out there. We've already been doing a little bit of that and want to continue that for sure.
Do you feel like it's very important for you to continually make this a forefront for individuals as they not only grow in their own lives age-wise, but to pass that along to the next generation?
Absolutely. We know if we can make changes in a certain person, then that can change generations, right? We've seen that with other issues. And so I think that is important to try to build that. I'm hoping over time. Right now, I focus mainly on adults. I really just see people 18 and over, but I'm already doing more education right now so that I will be able to start seeing adolescents and then eventually pediatric patients as well, where I'll be able to visit with families and try to make changes early on when we know a lot of those habits and everything start, and trying to make changes there that will have a ripple effect down the road. From my perspective, what I mainly focus on with alcohol is its calorie content. So a lot of people drink alcohol without really thinking about how many calories it has, and it can have quite a few. So when I generally talk to patients about alcohol, I look at how much are you drinking, and as long as it's not a concerningly excessive amount, then my recommendations are to just track it, keep account of it. You might want to spend those several hundred calories somewhere else. And if that's the case, then we can make some changes there. But I get more concerned if it's an excessive amount. Otherwise, I don't worry about it too much.
The future of obesity medicine.
Yes.
This is something very new to this area, still fairly new for you as well.
Yeah.
But what would you like to see different in the future with obesity medicine?
So one of the major hurdles that we have in obesity medicine right now is insurance. There are still several insurance providers, major ones, that do not cover either medications. A lot of them do not do that, or do not even cover visits, seeing your doctor about weight. That is, to me, actually an archaic way of thinking. That is going back to that old way of thinking of obesity as a willpower issue, that it's not a medical issue. And that's just not the case. We have clearly shown that it was declared a disease over a decade ago now. So it is something that insurance companies really need to change, and in small steps are making changes. So I'm really excited about where that is going and the possibilities with getting more people to have access to care over time. As far as obesity medicine itself, this is really an exciting time to get into this field. There are these new medications that are really effective, very safe, and I think that's going to just grow. We are learning more and more about nutrition and looking at what is called precision medicine, which is not just in obesity medicine. It's really something that we're looking at in the medical field as a whole. What that involves is being able to learn more about people's specific genetics, how they might respond to either certain medications, different treatments, And being able to get that information and then tailor the treatment for whatever condition to them, and that will be the most likely to be beneficial. So instead of starting, for example, with someone with high blood pressure, who we have many, many medications that we can choose from, and as well as changing lifestyle, like watching salt. We know some people salt intake doesn't affect their blood pressure, so we might know that ahead of time. Let's not even worry about specifically being really focused on the salt intake. Let's maybe look at these medications, and we know which ones actually will work for you and have the best chance of causing fewer side effects and being the most effective. We're actually looking at that very much in obesity medicine as well. Being able to have some information that tells us this is the type of nutrition, these are maybe the physical activities, the exercises that your body will respond to most, as well as medication options.
What identifies somebody as being obese?
So right now, that is defined by what's called the body mass index. So the body mass index is just a comparison of a person's height with their weight. And we define it as anything over a BMI of 25 is considered overweight, and then a BMI of 30 and above is considered obese. BMI has a lot of concerning problems with it. It's not a perfect measurement, but it is what we have. It's easy, it's reproducible, so that's what we use. There is a push to try to get obesity to be more defined by body fat percentage. So as I was mentioning earlier with the DEXA scan, being able to look at body fat percentage and have that be what we use as a definition for overweight and obesity, because somebody might be really muscular, so their BMI is high because their weight may be high for their height, but when we look at their body fat percentage, it's perfectly normal or even low, and we should not be classifying them as obese. So there's been a big push for that, but that's the current definitions.
Because I feel like there's a lot of people that maybe don't realize maybe that they're obese, just strictly because the pant waistline is the same, they don't feel uncomfortable, but in reality, they are obese. Mm-hmm. So the concern level isn't there yet. At what point does somebody need to be concerned about their weight for being obese?
At this time, we still using the body mass index. We would still say anyone with a BMI between 25 and 30 should at least visit with their doctor about their weight and if any changes need to be made. And then certainly 30 and above, we know starts increasing risks for heart disease, diabetes, blood pressure, cholesterol issues. And so at any point where that is the case, then it's a good idea to visit about it and see what might need to change. Again, there might be underlying circumstances where we understand why the BMI is over 30 and we can address that. But for the majority of people, if that is where they fall, then that discussion should occur.
Do things change age-wise on this as well?
So from a strictly definition standpoint, no, the age does not change. From looking at what is the healthiest weight as we get older, it does change. So we have actually found that people over the age of 65 that have a BMI around 25 to 27, so just into that overweight category, tend to have fewer health issues rather than the people that are below 25. We don't quite understand why all that is. There's a lot that can go into that, but that is what we have found. So when I'm visiting with people that are over the age of 65, I visit with them about that maybe we don't need to, if their goal is to try to push their BMI down, that maybe we don't have to push it as low as we would when we were younger. As far as children, there are specific definitions related to age with regards to that. It is important to me that a person be ready, that this be a decision that they've made that they want to go through and not be something their doctor wants them to do or their spouse or their child or parent or whoever. It really needs to be something they are ready to make. There's a lot of misinformation about nutrition specifically, but a lot of things with regards to weight management. And so when I bring up certain topics and show them what current science shows, there are a lot of times where people are surprised. Sometimes it takes a little bit of time to convince them because they have had, again, decades of information, and we know things change, science changes, and we have to go with what we currently understand. But a lot of things that even I learned in medical school just don't even make sense when you actually sit down and think about it. But it's the way that nutrition was taught for a long time. But then when you actually start looking at studies and what is actually being found, we actually find some significant changes. It can also help put in perspective the severity of the issue sometimes. Some people don't realize, even if their BMI is a little high, they might see their body fat percentage is actually even higher than what we would have anticipated. And that can sometimes be motivating that, oh, this, if I don't make changes, this is really good. So the main things it looks at, so it looks at the body fat percentage. So again, looking at, we can define obesity by different criteria on there. And so, for example, for a woman, obesity would be defined as a body fat percentage of 35% or higher. Just as there's different scales based on age there, but 35% or higher. And I've got some patients that are 55, 60%, right? So again, it just gives us an idea of where we're at with things. It also looks at the muscle mass. So how much muscle do we have? And I've actually found people that have what is called sarcopenia, which is just like you can have osteopenia, which is thin bones. You can have sarcopenia, which is thin muscles. And that is a major health problem because the muscles, are the tissue that mainly use calories. So if you don't have the muscle tissue, you're not going to burn calories. So that's just going to perpetuate the issue. You're going to actually gain more weight just because your body's using less calories for that. But then also that can lead to falls and other issues if you don't have the muscle mass to do everything that your body needs to do in a safe manner. So we can look at the muscle mass. I do a calculation that determines whether they have that condition and allows us to address that with more specific nutrition and physical activity recommendations if needed. So at the first visit, it's mainly information gathering. So I go through a person's history, health history, their medications, as well as getting that story of what has their weight concerns been like over life. Has it been from childhood? Has it been more recently? What's been the story there? And that helps guide kind of recommendations with regards to that. We talk about sleep and stress and all of that as well, and getting as much information as we can. And then going through those 4 pillars, trying to decide what can we do to come up with a plan. The scan is something we currently are only doing a couple times a month, so it's something we have to schedule and then have them come back for, and then I call them with those results. But we use that information to see what we want to do with regards to that. And then as far as follow-up, I individualize that with people as well. So most people visit with me monthly. That seems to be the most common time frame that's not too cumbersome, but is often enough that we keep some accountability. But I've got some people that do every week to start with, every other week. I've got some that go a little bit longer because of insurance concerns, but we just try to tailor that to what will meet their needs and what we need to do to make sure they can achieve their goals. So I do ask that patients that see me have a primary care provider. With the discussions that we do, we often find things that we either need to investigate further that's really outside of my program, but definitely is very important for their health. And so I need to have a provider that I can visit with and see if we need to do either further testing, further treatment options on a variety of different medical conditions. That's what I've really enjoyed being back here at the hospital. I have a great relationship with the providers here, and so I can just visit with them and kind of see what we want to do to help the patients.
How do people inquire about your program?
So they're more than welcome to give us a call here at the clinic at Holton Family Medicine, and we'd be happy to visit with them about the program. Also, they can find us on our website and then also discuss with their primary care provider if they'd like to see us.